So we all know that a collimator is used to restrict the size and shape of the X-ray beam, and therefore in turn it reduces patient exposure. A collimator is lined usually with lead and is fitted over the opening of the PID. Hi guys, so we are just following me around at work today. So this is just the layout of one of the operatory rooms that we have at work. The X-ray machine that we use at work is called Gendex. So a collimator can come in two different shapes. It can come in either a circle or it can come in a rectangle. So before they used to have a plastic cone-like collimator. It was shaped like a cone, and these weren't the best of the shapes because when the X-rays came out through the pointed end of the cone, they would produce excessive amounts of scattered radiation. So this collimator is no longer used in the dental setting. So the collimators not only vary in their shapes, but they also come in different sizes. They can come in two different lengths. They can come in either an 8-inch, which is the shorter one. This is the 8-inch. This is also the short one. Or they can come in a longer collimator length, which is 16 inches. We all know that long PIDs usually are preferred because it reduces the divergence of the X-ray beam. So what we have here, this particular collimator is different than the one that we have in Gleason, because the one in Gleason gets fitted into the round PID, as opposed to this one. This actually goes over and it fits over the round PID, and it kind of lengthens the entire collimator. So the difference between a rectangular and a circular collimator, the biggest difference can really be seen if you take a size 2 film. This is just an intraoral PSP film, and if you put this film up against the rectangular collimator, you can see that the rectangular collimator restricts the size of the X-ray beam to an area that's just slightly larger than a size 2 film, and that in turn significantly reduces the patient exposure. If you were to move this over onto the round PID instead, you can see that the circular collimator, on the other hand, produces a cone-shaped beam that's about 2.75 inches in diameter, which is a whole lot larger than the size 2 film. So this is how we're actually going to test our theory between the difference between a rectangular and a circular collimator. We're just going to take this piece of layout, and this square boxes that are evenly spaced are where we are going to be actually placing size 2 intraoral films. We're going to be taping them onto the squares, and we're going to be taking these black circles represent any sort of coins. And what we're going to do is we're actually going to take a round collimator, and this entire red area represents the 2.75 inches that are going to be exposed by the round collimator. So theoretically, this area of each film, about a quarter of the bottom of each film, should be exposed. If we were to take a rectangular collimator, which fits perfectly right in between all these spaced out films, none of the films should be exposed. Just so we have a baseline, we're actually going to not use a collimator at all, just to see the difference between having a collimator and not having a collimator, and if we were to have a collimator, which one would be better, a circular or a rectangular.
And now we're doing our first series of film, traditional film, D-speed film, and we're using a rectangular collimator. Okay, so we're doing our second series now. We removed our rectangular collimator, and we're just using a round collimator, and this will increase the X-ray beam size.
We just removed the round collimator. This is our last exposure. This is just going to show us the difference between round, rectangle, and having no collimator at all.
Oh.
Hey guys, I'm Erin. We're here in the dark room at Farmingdale State College. We're going to go through the process of how you develop traditional films. So Ruchi here has her developer. We're going to go in the developer, take it out, rinse it in the water, then go into the fixer. Then once we see the image start to appear on the film, rinse it one more time, Then we're going to let them dry and see what we have on the films. What we're doing here is testing the difference between a round collimator, a rectangular collimator, and no collimator to see the difference in the beam size.
So this is the one where we didn't use a collimator of any sort. These are the results that we got. As you can see, these two are manual processing errors that we underdeveloped them. So ignoring those two, you can see that these, because the beam size with no collimator was increased and it exposed the entire circumference of this, the entire film got exposed.
Go.
Okay, so I exposed these films. They've been developed now, and I used the round collimator. As you can see, it cut off portions of the film, and it reduced the X-ray beam size to the size of the round collimator, which is 2.75 inches, so that's why only a small portion of the film is developed.
I used the rectangular collimator, which shows here on the films, it showed that none of the film got developed. It shows that the rectangular collimator just had the X-ray beam fit right here in the center, reducing it from the round to the rectangular by another 2/3, which is the safest one. So we're here concluding our experiment, and based off our results, it showed that the safest way to expose a patient as a hygienist is using a rectangular collimator because it really reduces the amount of area being exposed to radiation. The second safest is a round collimator because it still reduces the X-ray beam, so it's really just directing it more in a generalized area. And the unsafest way is not using a collimator at all because it exposes the whole head of the patient. So what we want to say is,
use a collimator.
Keep your patient safe, reduce the amount of radiation.
The ALAR concept states that we in the dental community should expose our patients to doses of radiation that are as low as reasonably achievable to obtain a desired diagnosis or certain things that we are looking for on film. Rectangular collimators along with high-speed film are two things that we can implement to achieve this goal. However, many practices have not adopted the use of rectangular collimators due to increased errors in taking films, not properly aligning the device with the film and having cone cut and things like that, which you would think lead, or which obviously does lead to retakes and more exposure. There are many benefits to using them other than just radiation, reduction in radiation exposure. If you use an alignment device such as an XCP kit, you can align the rectangular collimator in the ring on the XCP kit and eliminate any possibility for cone cutting or errors like that. And with that kind of equipment, it will save you time and money in training new, inexperienced staff on how to take films properly. Rectangular collimators also reduce the amount of fog in a film because you're getting rid of a lot of scatter radiation, so you are improving your image quality. So again, it will save you time and money, or the dentist time and money, on training new employees if you use a rectangular collimator with the proper device such as an XCP kit to easily align the PID with the film and eliminate any possible errors. And it really does help improve image quality, which is better for diagnosing caries or pathology or anything like that. Here's an example of a complete set of films from the same patient at different times. The first set that I'm going to show you are radiographs taken without a film holder in the first two on top, and on the bottom is with a film holder. The second set, which is right here, notice the increased image quality, used a circular collimator, and the final one used a rectangular collimator, showing a better image quality. And just to show you how much of a reduction in radiation there is with a rectangular collimator, I'm just going to compare the effective dose for a full mouse series using PSP plates and F-speed film with a rectangular collimator versus a full mount series with F-speed film and a round collimator. So for the rectangular collimator, the effective dose as of 2007 was 34.9 microsieverts, and with a round collimator, it's 170.7. So that's a difference of about 140 microsieverts in the effective dose when you go from a round collimator to a rectangular. Also, the measurements of background radiation, the equivalence of certain series being done and their equivalent as in days of background radiation. A full mount series with a round collimator is the equivalent of 21 days on Earth of just regular background radiation. So getting a full mount series done with a round collimator is equivalent to just 21 days of the background radiation that you would receive in your everyday life. And that 21 days is reduced to 4.3 days when you do a full mount series, same speed, film, and everything, but you just change from a round collimator to a rectangular collimator. So you're taking off about 17, 18 days of background radiation when you just go from a round collimator to a rectangular one. So that is why they should always be used. Thanks.
Seen in these pictures, a rectangular collimator reduces the X-ray beam to the area only being exposed. When just a round collimator is used, only about 10% of the beam hits the receptor. The remaining 90% is either absorbed by the tissue or scatters onto the receptor, fogging the image. When a round collimator is used, it is exposing areas like the eyes, skin of the face, and possibly the thyroid to radiation. These parts of the body are very radiosensitive, meaning that these certain cells are very susceptible to harmful effects of ionizing radiation. Overexposure to the eyes can cause cataracts, and overexposure to the skin and thyroid could cause cancer. Using a rectangular collimator to prevent exposure to these areas is critical. Despite its advantages, rectangular collimation has been underutilized in the dental fields. Among the concerns cited are difficulties in using rectangular collimators, the possibility of a high number of cutoff errors, and the cost of acquiring new equipment. Oh, hello there. Let's continue our talk about rectangular collimation. Given the smaller size of the rectangular collimator, alignment may require more precision. Hence, practitioners may experience difficulty aligning the collimator with the receptor. Some stuff I'm reading here about it. It may occur more frequently when a rectangular collimator is used. These errors render the radiograph undiagnostic, requiring retakes and defeating the purpose of reducing unnecessary radiation exposure. Low cutoff errors appeared more frequently when a rectangular collimator was used. Studies have found it was a result of poor technique error, such as the PID was misaligned and the X-ray beam was not centered over the image receptor. More importantly, these studies have found that despite the cutoff errors, most of the radiographs were diagnostically acceptable and retakes were not required. Scatter radiation, a type of secondary radiation, occurs when the useful beam intercepts any object, causing some X-rays to be scattered. The larger amount of tissue the beam is allowed to hit, the more scatter radiation is produced. Rectangular collimation greatly reduces the amount of scatter radiation. A reduction in excessive scatter radiation increases image contrast, which is the difference in the degrees of blackness between adjacent areas, and also reduces noise or fog on the film. Adopting rectangular collimation assists in not only reducing patient radiation exposure, but also in obtaining quality images that lead to improved diagnosis and treatment. So in conclusion, reduce radiation with rectangular collimation.
Hi, we're back in the darkroom to develop our films. Here they are!
We're on to our last exposure, and this is just a baseline comparison. Blanking. gotta hit it and then.
Go.
Yeah, we're excited.
Crap.
Cutoff errors appear more frequently with this when you could just get this.